you again, everyone, for joining us today. For some quick background, we planned this webinar because we wanted to highlight the lessons your colleagues in Maine and Washington learned about working with primary care to prevent suicide. And because sustainability is so important, we also wanted to highlight efforts that occurred with little or no grant funding. We have a great panel of suicide prevention practitioners who have made inroads with the primary care sector at the community and state levels and within professional education. We also looked at the information you provided when you registered and know that many of you in the audience have experiences working with primary care and lessons to share as well. So we'll have an opportunity to hear your lessons a bit later in the event, and we want to thank you in advance for your participation. Today's speakers are Carrie Horne, Peggy West, and Elaine Walsh. We're going to take questions for individual speakers after each of their presentations, and then we'll take your general questions and comments towards the end of the event. Our first speaker is Carrie Horne. Carrie is the training director for the Maine Suicide Prevention Program and is a licensed clinical professional counselor in the state of Maine. She's worked in healthcare for 30 years and for the past 10 years developed and implemented the training program at NAMI, Maine. The foundation of Carrie's programs and training expertise is direct practice and clinical knowledge on mental health, in addition to working closely with families through NAMI, Maine. Carrie, please begin whenever you're ready.
Thanks, Lisa. As Lisa said, I'm Carrie Horne. I'm the training director for the Maine Suicide Prevention Program and representing the efforts of this program on this call today. The Maine Suicide Prevention Program is nestled within the Maine Injury Prevention Program, which is within the State Centers for Disease Control and Prevention in the Maine Department of Health and Human Services. Operating on a dwindling state funding, the program provides statewide leadership for suicide prevention, intervention, and postvention. We stay abreast of the current national research. We provide access to data regarding suicide and attempts and develop a strategic plan for suicide prevention for the state. And that's all in addition to the training and education component, which I manage. The program is led by Cheryl DeCara. So I'd like to give you some information about Maine to set the stage for my segment of the presentation. Maine is totally a rural state. The total population of Maine is about 1.3 million people. And to put that into perspective, it's a little less than the population of Greater Philadelphia and about half the population of New York City. Much of the state, about half of the state, is what's called unorganized territory. So we experience many of the systemic healthcare challenges that other rural states experience, including transportation challenges to healthcare access points for behavioral health care and primary care both, long distances from home to healthcare, as well as shortages of professional health services. Our suicide rate is usually higher than the national average. In 2009, Maine ranked 15th highest in the United States with a rate of 14.9 per 100,000. So I'm going to talk a little bit about Maine's approach in engaging primary care physicians. Our first step was to engage stakeholders, which included state leaders, practitioners, clinicians, and consumer groups to engage in a discussion about engaging primary health care and integrating behavioral health care by hosting a symposium in June 2010. This symposium featured the introduction of the Suicide Prevention Resource Center WICHE Toolkit on suicide prevention in rural primary care. This was the beginning of our efforts to engage primary care and suicide prevention and opened the discussion with Maine Primary Care Association, who is a key organizational leader in promoting quality care in their membership organizations. As a direct result of the symposium, the Maine Suicide Prevention Program and the Maine Primary Care Association made a commitment to take action on integrating suicide prevention, intervention, and postvention into the primary care arena in Maine. Partnering with the Maine Primary Care Association was excellent strategically to bring about systematic change in primary care in Maine. So a little bit about the Maine Primary Care Association. The Maine Primary Care Association has 18 member health centers, and each health center represents anywhere from 1 to 11 primary care sites. They all cover the entire state of Maine. So you can see on the slide in front of you the breadth of the state of Maine that's covered by these health centers around the state of Maine. Their membership includes federally qualified health centers, Indian health centers, and island-based health centers. There's some other reasons why they're a good match for the collaboration, and those include that federally qualified health centers and their staff tend to be mission-driven, their mission being to serve the underserved. So I think that was a great match for a suicide prevention program. They specialize in rural health care and are based in the community, and they also have a statewide reach, as you can see from the slide. Most of our federally qualified health centers were already involved in a behavioral health integration program to some extent, and also federally qualified health centers routinely screen for depression. The health centers had their initial introduction to the Toolkit, as I said, through behavioral health integration projects that were supported through the Maine Primary Care Association, and then also that symposium I talked about. After that, we asked for health centers to volunteer to be a pilot center, and then to make a commitment to incorporate suicide screening, policies and protocols, staff training, be involved in staff training, using the Toolkit in exchange for specialized training and technical assistance for the program. Maine Primary Care Association took the lead in implementation and engagement, oversight, and technical assistance. Our first steps included identifying leadership and a champion within each pilot site. One of the primary goals that we found that we all shared is the idea that incorporating suicide prevention and intervention is the right thing to do. Primary care is a key vantage point for intervention and can provide guidance in saving the lives of patients. In addition, some benefits from the primary care center's perspective included improving the comprehensive health care for patients by incorporating behavioral health care in the centers, improving the practice's resources and response to their high-risk patients, providing some structure and efficiency to their efforts to provide integrated behavioral health care. One concrete way that they did this was to provide a protocol for screening and assessment of patients that were seen within the center. We're going to talk a little bit about our steps that worked in our program in Maine. First of all, it seems like this would be common sense, but it took some time for all of us to realize that adopting the Toolkit didn't automatically mean that we had a suicide prevention program. It meant lots of hard work that's represented by each of the steps identified in our programs and the Toolkit. So in other words, we didn't use the Toolkit as like a cookbook or a recipe for a suicide prevention program. We used parts of the resources and planning steps that we felt worked with each individual health center. At the same time, some planning does help. So we found there were some basic steps from the Toolkit that should precede others of steps in the adoption of the program. Some of the steps that helped us to lay the foundation in our health centers were the development of procedures and protocols, role development and identification of the champion within the health center that would guide the process, and then also staff training. We found that each center had to confront a shift in role and culture of the health center to adopt a suicide prevention program. When we started to work with the protocols and procedures of the program, some changes in responsibility and communication flow needed to be identified within the health center. Technical leadership and a champion also helped with this adjustment for the health centers. All of our health centers reflected the communities in which they served, and each had a very different culture. It took some time to get to know each center and their leadership, the community culture, the health center culture, what resources they had internally within the health center, and also what they could reach out to the community to take. Also, each center seemed to have a unique understanding of the behavioral health care system, and that kind of depended on the resources that were available in their communities. I also think it was important in engaging health centers to let them know that we realized that they were working with so many competing demands that were placed on the health center staff and physicians, like documentation and other programmatic enhancements of quality care. So there are things like programs like the patient-centered medical home model that they're working with, and also behavioral health integration model, all the documentation and coding. Because of this, we attempted to make our program easy for the health centers to integrate and adapt into their systems. So we looked at things like helping the centers to work out the flow of patient appointments and procedures that would help them to adopt the program. We had to learn the language of the health centers, their structures and positions to help them to construct their own program within their own center. Each center had different staff structure and capabilities, so some had behavioral health clinicians that were involved in the center, some had program directors, some did not, some had care managers that were responsible for high-needs patients, and then some had care facilitators that were in charge of follow-up care and contact between appointments with patients. We did have available resources that were already in place for our program. They included Maine Primary Care Association's resources. They had access to the administration in each partner center through membership, and they also had access to champions within each site. Maine Suicide Prevention Program had already developed a statewide training program for suicide prevention that was made available to and accessed by health center staff throughout the year. We began our effort by offering training to administration and key staff in each interested health center on the Toolkit and the suicide awareness education. We also did outreach then to each health center staff in each region to make them aware of the trainings that were already available to them statewide so that they could access them. We also offered them the materials and led them to materials that would help them in their effort. Tools from the Suicide Prevention Resource Center, the Toolkit, the safety card was really well accepted. We found that health center sites often had to reach out into their communities to provide a continuum of health care, including behavioral health care. Some community resources that needed to be linked to from some of the sites included a higher level or more specialized mental health care in the community, opportunities for support groups or support group networks that might be available in the community as well, connections with hospital emergency departments and crisis care, and also safety planning with local law enforcement. Our health centers really wanted these links. They wanted to have a resource list which was developed for them, but also we felt that face-to-face introductions were important, including we had networking plans, and we also had things like training panels that brought these professionals, community professionals into the health center. System change in our program. Instead of looking at the numbers of health centers we've engaged and what we've attempted to do to educate staff, we're beginning to look at developing milestones for systems change for our program. For example, at first we looked at counting system contacts, coaching sessions, stuff like that, who was introduced to the toolkits. Now we're shifting to identifying what we're calling change components for our program, like our progress on universal screening for depression or identifying commonly used reimbursement codes that physicians can use for behavioral health treatment. So just to recap, the things that seem to have the greatest effect on engaging health centers and supporting system change in our experience were working with each health center on developing policy and protocols, reviewing them and making sure that they incorporated suicide intervention, the work on relationship building between our program and the health centers, including accepting and expecting, actually, each to have a unique culture. The idea that this would be incorporated into an efficient system for them that would help to manage the day-to-day patient flow, and encouraging the health centers to take another look at their screening process. and whether it does include suicide screening, whether it's indicated screening with just some of their patients or universal screening that they're using. And finally, moving forward, what we do plan to do next is evaluate system change, as I talked about, focus on screening for suicide in our sites, focus on practice change and improvement at each of our sites, so increasing screening rates and referrals for behavioral health and mental health services. We're looking at physician training in particular, so trainings like the RRSR through the Suicide Prevention Resource Center, and then the use of the Toolkit as one of the many resources available for primary care. And then finally, engaging health centers, additional health centers to our program. And here's our contact information in case you want to get a hold of us. Lisa?
Great. Thank you so much, Carrie. We want to open it up for folks to ask Carrie questions about her experience in Maine. So I'll give you a minute to type any questions that you might have into the chat box. And as a reminder, the chat box is in the lower left corner. In the meantime, oh, okay. Great. Corrine, can you describe how you complete the EIRF? And that's an evaluation tool for Garrett Lee Smith grantees.
We don't have a Garrett Lee Smith grant. We're definitely on a shoestring budget here.
Yeah.
So.
Great. And so that's you, and you described your evaluation planning a little bit. Is there anything else that in your evaluation that you've had to develop infrastructure for, or can you tell us a little bit about how you've gotten the provider settings to meet some of the evaluation requirements that you might have?
Really, so I really would be remiss without thanking Becca Moran, who's the Director of Clinical Quality Improvement at Maine Primary Care Association. She's really been so great in engaging the primary care physicians, and also she's been helpful in identifying our change components. So we really had to take a look at, what were we really wanting to evaluate here? It wasn't counting, our contacts. Really, it was, we want to see how change is happening in our program. We're still developing that, so to be continued, but that's where we're going with the evaluation.
Great. There was another question about what's in the toolkit, and I think Peggy West is going to address that briefly, and Adam Chu is going to be pasting the link to the toolkit in the chat box in a little bit, so we can address that question in a little while. Another question is, how did you engage the primary care providers? Maybe what was it that really what got them to act? I think there's a lot of barriers sometimes for them to have to add one more thing.
Mm-hmm. Well, really what I wanted to say is Maine Primary Care Association was fundamental in engagement here. So we did it from, a membership level, from a oversight level, membership group level, rather than trying to engage each primary care practice. So really offering a program to a lot of different federally qualified health centers, and I did talk a little bit why that was a good fit for this program, I thought. I think that membership organization really was very helpful in the engagement process. I think that people, that primary care physicians really want to go there. They really feel the need and think it's important. It's just, competing demands and, the nitty-gritty of every day, documentation and everything that they have to deal with, that's the barrier. So really, pleading to, their hearts and reminding them that this is comprehensive health care and engaging behavioral health programs.
Thanks. There's also a question from Adam Lesser about screening tool and treatment models that you're training them in. Do you have specifics on that?
Yeah. we're changing our focus this year. So this is the second year of our, really going full speed in this program. Federally qualified health centers here in Maine generally use the PHQ-9 for screening for depression. And what we've identified last year is that really the PHQ-9 does not have focused suicide screening questions. So we're looking at alternatives to the PHQ-9. Also looking at, what we need to look at is, gosh, all these physicians now are using the PHQ-9. How are we going to sell them on another screening tool? So that's to be continued as well.
Great. And I think most of you should be able to see that Adam posted the primary care toolkit URL there. There were some other questions that I think you addressed and that we'll also hear more about, so I'm going to move on, and we'll also have questions at the very end. So I really appreciate everyone participating there. Now we're going to hear from Peggy West, Senior Advisor with SPRC, who is based in Seattle, Washington. Peggy has over 40 years experience working in and with behavioral health, healthcare, and public agencies. She has extensive experience working with primary care providers and provided postgraduate training for physicians, nurses, social workers, and other health disciplines at the Center on Human Development at the University of Washington. Peggy also worked in the Region 10 office of the Health Resources and Services Administration, leading efforts to advance suicide prevention in Western states. She's been a senior advisor at SPRC since 2007, providing leadership and consultation as a member of the Science and Policy team. So Peggy, whenever you're ready. And you may want to check if you're on mute, Peggy. Just a minute, and we'll make sure that Peggy's with us. So I think while we wait to see if Peggy can join us, Adam, is the poll, we had a poll that we wanted to ask our participants about their experiences with behavioral health and primary care. Is that something we can pull up right now? Okay. Okay, so everyone should see a poll in their screen. Are you working on a collaboration between primary care and behavioral health? You can check a yes or no. I'm going to wait a minute just to give everyone a chance to answer. You can kind of see the different responses tabulating. So looks like about 2/3 of you have. And for those of you who have, we'd just be interested in learning a little bit more about what those kinds of collaborations have been. So if you can type them into the chat box and just give us a brief description of what those collaborations are, then all of the audience can see what you've done. So the RRSRPC is American Association of Suicidology project, and it's an online training for primary care providers. And we heard a little bit about the PHQ-9. Coordinating behavioral health referrals with outreach activities in an Indian healthcare clinic. Great. I think we're getting multiple people typing at once, so we'll see a few more examples.
Okay,
County
I'm here
and city
now.
Coalitions. Oh, great. Thanks, Peggy. Okay, we'll just take one more minute to hear what the examples are that folks are submitting from the poll, and then we'll get started with your presentation. All new patients see a behavioral health specialist as part of the new patient appointment. Wow, that's great. Statewide learning community for BHI. working with a pediatric practice to have a counselor available. Great. Well, thanks everybody, and we'll be able to see all of these examples after we archive this too, so I'm excited to learn more. Okay, so we're going to close the poll, and then Peggy will get started.
Okay, thank you. I'm sorry for the problem. Somehow I seem to have gotten muted centrally, like the rest of you who are on the phone. Anyway, I'm delighted to be here, and thank you for the opportunity to share the experience that we've had in King County, Washington, with our community-based effort. It's a little like, some of you may remember a story on stone soup, where the beggars came to a town and said they were going to make soup out of stones and put a pot in the middle of the town square, put 3 stones in it and water, and invited the town people to share whatever they had to put in the pot, which ended up including many offerings that made the soup taste great. Now that's my shortened version of the story. But this is what we've been doing in King County with creating an effort for preventing suicide that ended up focusing on primary care. So I want to tell you a little about our experience here, and you'll hear more about how this has grown when Elaine Walsh talks about her training with nursing students. In case you aren't familiar with King County, Washington, we are the most populous county in the state of Washington, and even though I work for SPRC, which is in Massachusetts, I live here in King County. King County has somewhere between 220 and 250 suicides per year. There are more suicides than car crash deaths, HIV/AIDS deaths, and homicides all combined. And the majority of these suicides are among people over age 22. And as we learned in our beginning efforts to bring people together in King County, most efforts to date for preventing suicide have been youth-focused. So as you can see, we really didn't have efforts that were focusing on where most of the suicides were occurring. So we got together a very loosely organized coalition. We had no additional resources, no grants, and we reached out to anyone who was working in the county who was trying to prevent suicide and wanted to come and share experiences, information, and an opportunity to do some things together. The group was made up of a wide range of professionals in King County. The crisis clinic here offered meeting space where we came together and were able to meet comfortably. And we were focused on trying to not only share our experience and resources, but also to develop some opportunity for what we could do together. As I said, we had no additional resources, but we had a lot of passion. The coalition members include people from Public Health of Seattle-King County, the Seattle Crisis Clinic, Veterans Administration, University of Washington School of Nursing, King County Mental Health Chemical Dependency Programs, University of Washington Health Center, at Northwest Hospital Geropsych Center, and a number of others. So this gives you an idea of the range of diversity that we had in our group. Group has been meeting for 2 years, and the data that you see here was something that struck all of us. As we shared what might we do together, we began to look at, well, what places might we reach this group nobody was reaching, the adults who were making up most of the suicides in King County. And so we knew that many people who took their life by suicide had seen a primary care provider in the month before their death. Well, this seemed to us like an opportunity we could learn more about, and especially an opportunity where we might reach adults who didn't seem that any of us were reaching. the primary care providers were writing most of the psychotropic prescriptions for people that were being filled. So we knew that primary care providers must be seeing people that they knew had problems that would put them at risk because they were writing prescriptions for them. We also knew, as has been mentioned, that there were resources. We didn't have any money, so we didn't have the ability to create resources. So we knew that that resources did exist that we could draw on, and that was very important to us since we were not going to be able to develop new ones. Several questions have been raised about the primary care toolkit. This is entitled the Suicide Prevention Toolkit for Rural Primary Care, but we think it has had good relevance for King County, which, though it has some rural areas, is predominantly urban. And we thought that the materials in this would be helpful for having us learn what might be able to be done. I've been fortunate to work with the Western Interstate Commission on Higher Education and Development of this toolkit, and it is free and available for you to download, and Adam has put the URL in the chat box. And in fact, we at the coalition were able to print the toolkit totally from the URL, and the county mental health folks used their printer, printed this out, and each person in our coalition had a copy of it. So again, this was an in-kind contribution of paper and time to print this, but we didn't have to go out and purchase something for all of us, everyone in the coalition, to learn more about what might be done in primary care. You've heard a little from Carrie about the materials in it. And essentially, in this toolkit, there is a primer to give primary care providers information about suicide, and also a guide for how to get started in a practice so that the practice can make a plan for how they're going to incorporate this. There is a pocket guide for primary care professionals that helps them with assessment and knowing what the risk might be for patients that they're seeing that they can use. This pocket guide can be printed from the URL. There's a safety planning guide, which you'll learn more about from Elaine and how she has incorporated this in training for the nursing students. There's information in the toolkit about how to reach out to mental health providers and increase the relationship with them for referrals. There's information about putting together material on state resources and policy. And there's also some tips for billing in the primary care setting and links to many other resources that people might want. So those of you who want to learn more, I encourage you to go online and take a look at this, and you can print out those things you think might be useful. One of the things we did in our coalition was, after we got the idea that there were resources to work with primary care and that it was something we thought we might tackle, we invited a physician who was in private practice in the area to come and meet with us to see if our thinking was on track and to learn about his years of experience and whether, in fact, this was something that a physician who was in a large private practice thought was worth pursuing. And in fact, we learned from him that this was something that he saw coming up in his practice, not only for himself, but others in his group, and encouraged us to move forward with. So we considered, if we were going to do this, what approach might we take? And, you know, there are many approaches that could be taken, and part of the reason for our choice of an approach was what did we think we could do and what resources could the group contribute that would make this possible. So it was largely driven by the resources and the people who were there. And we considered a number of these options you see on the screen, but we ended up concluding that we wanted to do a community-based continuing education for professionals working in primary care, because this was something that we were able to identify resources within our group we would be able to use. So again, this was very practically oriented. This is the brochure we developed, and we lined up speakers from our group and recruited a couple from outside of our group. We created a brochure, and we only, even though this looks like a print brochure, we only created it electronically because we didn't have a budget for printing or mailing. But we were, with the help of the hospital that's a partner, we were able to make this look very nice, and we sent it out electronically to a large list of people we could identify from within the members of the group. We used a Gmail account that we created for registration because we didn't want this identified with any one person's organization. You see that UW Medicine is on the brochure, but that was because they helped print, and also it was at Northwest Hospital where we had free space to use to put on our training. So we were very pleased with how this turned out, and it turned out we had more than 100 people register and about 85 people show up for the training. When we sent this out, we really had no idea who would show up or if anybody would show up, but this was our own experiment, and we were very pleased with the results. The content of the training, we had 4 different speakers, but the content focused on what was the prevalence of suicide in our community, in King County, not nationally, not in the state, but we really wanted to focus on what was the problem here where we were living. What were the warning signs and risk factors we thought that people who work in primary care would be likely to see, and we would hope they would pay attention to. We had key questions for a brief assessment, and again we used the guide that's in the primary care toolkit. That's the little pocket card. We went over safety planning and tracking, and a big part of the training also included accessing mental health resources that were in King County, and this was presented by our partner at the crisis clinic. And so this was a pretty broad presentation, and it was also made available to all the participants, as was the toolkit, on a thumb flash drive that we had available, and we had a volunteer who loaded all this information onto every thumb drive. We found that a handout table was useful, and we shared materials that coalition members had, and a lot of free materials that are available through SAMHSA. These materials were very popular. There wasn't much left to take home. The flash drives with the toolkit on it and local resources for presenters turned out in our evaluation to be rated as very helpful. People would have liked more training than we were able to provide on warning signs and safety planning, and you'll hear more about how to work on that from Elaine. And people also liked the office-based approach and would have liked breakout sessions or time where we could have had people meet by practice settings. As it turned out, we had a number of physicians, a small number. We had nurses, nurse practitioners. We had a number of mental health professional groups, most of whom worked in or directly with primary care practices, and we had a podiatrist, an occupational therapist, and a number of interested participants from a range of other community-based programs who saw individuals at risk for suicide. We were able to get the participants to fill out evaluations. We had a little carrot approach, and that was that to get the thumb drive, they needed to turn in an evaluation. So we did get evaluations from most of the participants, and this was very helpful for us to learn what people liked and what we might do if we repeated this. Our future work is that we would like to do this session again, and we're working towards doing this in the fall at another part of the county with another hospital setting that we hope to find that will be able to offer us free space. And this is also driven in part by our awareness that the state of Washington passed a requirement for continuing education for licensed mental health professionals and chemical dependency professionals in suicide prevention. And it does cover all licensed mental health professionals. The estimates are in the state of Washington, this will impact about 28,000 individuals. And we are hopeful in the future that we'll be able to reach out to nurses and physicians to encourage them either voluntarily or perhaps at some point get them included in the requirement for continuing education in suicide prevention. And there was a webinar in July about this law that some of you might be interested in, and there's a link here where you can go to download this webinar, the slides, and information about this law, because we know that this is something that a number of states are interested in moving forward on as well. I see that Lisa answered the question there was about the toolkit and getting hard copies, and I just want to add that what we learned in our effort is it really is possible to download this toolkit from the website and to make hard copies yourself. And the purchase of a toolkit for anyone who wants to, it is offered at cost, really as a convenience for those who might have trouble printing, not because we want to control access to it. We're eager for others to find ways to use this. So thank you very much, and I look forward to opportunities you may find to put this in action in your community.
Thanks so much, Peggy. And because we did some individual questions to you, I think they probably might have some. And while we wait to see if they do, I wanted to go back to one of the efforts that someone described and just highlight that there are some campuses on the call today, and Taisha Caldwell let us know from University of California that they are connecting college counseling centers with college health centers. So there's another subset of primary care settings to think about in our work. So if anyone does have questions for Peggy right now, you can type them into the chat, and if they come a little bit later, then we can revisit them at the end of toward the end of the session. So I'll just wait another minute. Great, looks like folks are ready to move. Oh, sorry, there's one more coming. I'll be patient. Is there an impact on the suicide rates thus far? Is that something you've measured, Peggy, or do you have anything to comment on for that question?
No, we have no. We of course follow the data that is put together by the medical examiner, but we don't expect from this effort that this alone would impact the suicide rates. And of course, as you know, that the data that comes out is quite delayed. There's a time lag. We do hope that it will increase the number of health settings where people are asking about this, and that it will be a way that people will incorporate this into their practice.
Great. And there was a question about asking me to repeat the comment I had made about the college health efforts. Taisha Caldwell from University of California let us know that they are working on connecting college counseling centers with college health centers so that all students are screened when they attend a health appointment. And I just was interested we don't always get to hear from campuses and what efforts they might be doing in terms of health care and primary health care for students. And so I just wanted to point out that comment that she had submitted. There's another question from Brian for you, Peggy. Have you identified the risk factors that contribute to suicides in your area? Or was that part of the process when you put together this training?
It wasn't part of our process. That we've not been a research project that has tried to look at risk factors. We do know that about half of the suicides are by firearm. And we do know that a lot of them are in adults that we have not as yet had much focus on. And so that's something we hope that there will be an opportunity to learn about, but there's no single agency that has had a focus on that to date.
Great. Well, thanks so much for those questions, and thanks for your presentation, Peggy. Now I'd like to introduce our third guest presenter, Elaine Walsh. Elaine is an associate professor in the Department of Psychosocial and Community Health at the University of Washington School of Nursing. She's an ANCC certified clinical specialist in child and adolescent psychiatric and mental health nursing. Elaine has extensive experience working with youth and families in hospital, school, and community settings. She also served as a research scientist and project director with the Reconnecting Youth Prevention Research Program at the University of Washington. So Elaine, whenever you're ready, you can start your presentation.
Okay, thanks, Lisa. Can you hear me okay?
Yep, we can hear you.
Okay. First of all, just want to say thank you for allowing me to be a part of this really important presentation, and hello and welcome to those who are listening in. Just wanted to tell you quickly about our students at the University of Washington School of Nursing. The students that we work with, by the time we get them, are juniors and seniors, excuse me, in our undergrad program, and they go through a 2-year program. We also have, and that's about 100 per cohort that we graduate each year. We have accelerated Bachelor of Science students as well, so they go through the same undergraduate curriculum, but they do that in 5 quarters. And our accelerated BSN students have a previous degree in another field, some very diverse fields sometimes, and other times healthcare-related fields. We also work with 2 kinds of graduate students, the traditional research-oriented PhD students, and then advanced practice students, and that might be a master's degree, which is a 2-year full-time program, or a newer concept, which is something that some areas are more or less familiar with, which is the Doctor of Nursing Practice. And so that is a 3-year degree, and the students have a more intensive clinical research and leadership experience. So the standard of care, according to the American Nurses Credentialing Center, would be by the year 2015 that entry-level practice for nursing would be at the master's level instead of, at the DNP level, instead of the master's level. We'll see if that really happens in that time frame, but right now we're educating students to expect that it will be a DNP and finishing up with our master's students. So probably more than you need to know about us, but in terms of who we're dealing with, it's very important, obviously, that nurses are a part of suicide prevention efforts. They're on the front lines of patient care. Most of the time, observations and interventions that they make are critical to patient welfare. And of course, in nursing as well as any healthcare discipline, patient safety and health promotion are our priorities. The other thing that's important about nursing is that nurses educate and serve as role models for patients, for significant others, for other healthcare providers, and I think for any of you who work in healthcare, you're never really off the clock, so if someone knows that you're a healthcare provider, they're often looking for and listening to what you have to say about significant issues. So we also see this as an important just community-based issue as well. When we're looking at educating nurses, the things that I consider as an educator and that we look at with our curriculum overall is, first of all, what would we expect of the average person? And part of that would be noticing and being willing and able to help someone who might be at risk. So I start with my undergrad students and say that, that we would hope coaches, clergy members, the average citizen who's working with the public in some way would be able to notice and help identify people who might be at risk for suicide. We also look at what's the scope of practice of other healthcare disciplines. And then when we're teaching the nursing students, obviously we will have different levels of education, but what we want to think about is, that we'll have our generalist RNs who will be out and about. Many of our students want to work in hospitals and think that that's the best place to start. Many of them do. But what we're finding out, especially as our population is aging, is that we have students out in the community as well, and so delivering primary care or working in more primary care-based settings is definitely going to be the future. So a generalist RN will certainly need this information. A person who has more concentrated focus on psychiatric nursing, we would expect to be able to not only notice and identify and get help for someone, but they would be a part of the treatment team usually who would be managing these kinds of risks and situations. Our advanced practice nurses, on the other hand, whether they're psychiatric mental health or in other advanced practice roles, are people who are going to not only need to identify and be able to assess, but they're also going to need to be a part of the team that puts together a plan for safety. And a psychiatric mental health nurse will actually be involved and should be prepared to be managing suicidal behavior over time, and many primary care nurse practitioners also end up in that role, either on their own or in consultation with a psych mental health provider. It's a big issue in Washington State because our advanced practice nurses are able to practice fully independently. There's no requirement that they be linked up with a physician to co-sign or to provide supervision. They also, advanced practice nurses in our state also, and many other states also have prescriptive authority. So in looking at independent practice, prescribing medications that certainly are factors sometimes in risk for suicidal behavior, we see that it's critically important that nurses have this knowledge and this information. And what we try to do when we're working with our students at any level, first of all, is increase awareness about the issue of suicide risk, decrease their discomfort and their fear, and I think that's something that we see at many, many levels. Brand new nurses, experienced nurses, people have different degrees of comfort and experience. So what we're trying to do is decrease their fear that someone will say, yes, I'm at risk for suicide, because if we're afraid of that response, then we're not going to be open to hearing that in the same way that we should be. We also want to provide guidance and principles about what to say or not say, and practice, practice, practice. That's a big issue as well. The level of detail and complexity that we are going to be going through with the students is going to depend on their level of clinical preparation, obviously, and on their specialty area. But in general, what we want to be thinking about in speaking with and working with any of our nursing students is they need to be aware and they need to be prepared that anyone that they see could be at risk for suicide, that reaching out and expressing concern can be a powerful intervention, and that they should be ready, willing, and able to hear yes when they ask about suicide risk. And we talk about how you might ask a question in a way that you can hear yes as an answer. And one of the things that we struggle with students and even working with educating families sometimes is asking a question in a way that you sort of don't invite a yes, such as saying, you're not thinking about suicide, are you? And even the best intentioned people sometimes will not ask a question in a way that is more open, which is an example that's more appropriate, of course, being something like, are you thinking about harming yourself or about suicide? We want to be more direct about that. We also want our students to know their resources, and even if they're not feeling super confident, that we want them to present with confidence. They are the ones in charge of this situation, and they're, as the healthcare provider or healthcare team member, they're the ones who need to help take control of what's going on in a situation with a suicidal individual if that person is actively suicidal. This list of bullet points, things above the purple line, we'll be teaching to and expecting our students at any level to be able to do. Below the purple line, we would really look at our advanced practice nurses, psychiatric nurse practitioners definitely, and some of our primary care providers as well will be engaged in this kind of behavior. But basically that we want them when they're interacting with their clients or patients, to be able to introduce the topic of suicide so that the person, just as we all know we can come to our provider when we have a headache or we have an infection, that we also want people to understand that we can come to our providers when they're thinking about suicide or when they're thinking about harming themselves or doing something that might be dangerous as well. We also want to keep the discussion going. For someone who maybe this is not an issue for right now or someone who's not quite ready to trust us yet, we want to be sure that this continues to be an open dialogue. We also want to be sure that they provide support and then connect folks with resources. If there's immediate risk, those tend actually to be the easier situations for healthcare providers. It's pretty obvious when there's immediate risk that they need to get help and to intervene by activating emergency services. Below the purple line there are more difficult sometimes, and that is how to actually manage the risk long term and manage the risk in that moment as well. So we do, I think I'll speak just for our program, and I'm a big part of the development of our program at this point. We do a wonderful job of teaching people to do assessment, and what we really need to continue to work on with our nursing students is to be able to then manage risk over time as well. What we do a lot of is practicing, and in general what we want to provide is, first of all, simple scenarios. Sometimes when we ask people to role play, that we sometimes get, if they make up their own, they sometimes think of the absolutely most complicated thing that could possibly ever happen, and most people to role play. And with the scripted responses, for many people it's helpful at first when they truly don't know what to say, and we ask them to then think about how they might vary this quote-unquote script to be something that works well for them and adapts to their own style. And what I do, for example, with my psych nurse practitioner students would be, in practicing working with a situation related to suicidal behavior, would be having them be prepared to work in pairs, if I can divide them into twos, so that one would be the patient and one would be the provider, and then they would switch roles. Or I can also put them in threes and have the third person be the observer, and then we just go through the exercise 3 times. The important thing is to do a demonstration first, provide a good model of what it is that we're hoping that people will see. And it doesn't have to be a perfect demonstration, but what we want to do is to show how to do this the right way. If people get off on the wrong foot or they get a bad model from the person who practices, then we can sometimes have some overcorrecting that we need to do. And I usually just give a scenario or 2 or 3, if they're working in threes, vague enough that a person could adapt that to their own ideas, but also that they would not be making up a scenario completely. So I just put a couple examples of profiles that I might give our students, just giving them a sense of age, support, and then what kind of suicidal behavior or lack of suicidal behavior that they might have, so that students get a chance to practice those scenarios. And we're very fortunate to have the safety planning guide from the SPRC Toolkit. And that's actually something that I incorporated right after it came out and have used with my classes since then. And I just want to give you an example. We in the state of Washington are probably like most states. Our budget is not in good shape. University of Washington, we've had more than a 33% cut to educational funds from the state. So in terms of saying, could we buy this, could we add this, that's really not something that we have a budget for, and we're trying not to offload all of our expenses onto students. So something that I can download from the web, make copies of, is perfect. It's been very helpful, and students have been delighted with the opportunity to take this planning guide and be able to copy it for themselves and use it in their practice. And basically what we're doing with the safety planning guide is going through the steps which are very clearly outlined in the toolkit. Step 1 is warning signs. So how would we know when the safety plan should be used? What do you experience when you start to think about or feel extremely depressed? So I'd be sitting down with my client, and the students in this situation are going to be sitting down with their pretend client and going through this. And the second step with the client, what are their internal coping strategies? What can they do on their own if they become suicidal again to help themselves not act on thoughts or urges? How likely do they think that they would be able to do this if there was a time of crisis? And what might get in the way of being able to implement these coping strategies? The third step, excellent resource for many people, is what social contacts might help distract from the crisis. So social things they could do or settings that might take their mind off things for a while. What helps you feel better when you socialize, and to really work through with the client all of these steps. Fourth step being family members or friends who can offer help, so moving from distraction to actually getting some specific help for suicidal thoughts or behaviors. Who in their family or among their family or friends would they be able to contact, who can be supportive of them, and really to work through this worksheet and have that information on that sheet so it's at hand and available. The next step would be professionals or agencies, and again, as the provider, we would work together with our client. We would probably be more active in this step in terms of talking about who's available ourselves as providers and how we might be contacted, crisis line information, and then in an emergency where they might go if they needed help immediately. And then finally, the sixth step, making the environment safe. So what we want to do is work collaboratively with our patients to be able to see what they have in their environment that might be unsafe. We want to do that very carefully. We don't want to be suggesting ideas that people had not thought about, but a standard question certainly is, do you own a firearm, such as a gun or a rifle, and are there other means that you have considered using, and to really work with the person on getting those out of the environment. And then just in general, the practice guidelines that I use in my classroom are for the student who's going to be the client. We want them to be moderately cooperative. This is, with practice, what we're really hoping for is that someone has a successful experience. So I ask students if they have some more wild situations or ideas, that I want them to run them by me and not on their peers. That they're not auditioning for an acting role, so that it's really about the person getting the practice. And also not to portray themselves or a specific client. And then my job as a faculty member is to circulate, listen to people practicing, provide corrective feedback in the moment. Then I bring the group back together, ask students to give examples of what was effective, either words or behaviors that the person who is the provider in the provider role was doing. And then I also summarize and talk about challenges and provide some guidance. Usually if one group has had trouble with a situation, probably another one will have had it as well. Challenges, certainly no one likes to practice, and yet we all know it helps. We'll also sometimes have people who say they already know how to do this, and in those situations to say, that's great, show me, is something that people sometimes resist. Also in a large group, you can't hear everything, so you've got to be careful that idea correction can take place and not that practice not get into a situation where they're practicing something that's incorrect. Also, lots of people will have personal experience with suicide or suicidal behavior, and a chance to share that information is something that they might see this exercise as. And so that's just something that I can talk to you more about if there are questions about how that would be handled, but that's something to keep in mind. And then certainly people will talk about not having resources in their area. And one of the biggest issues we talk about with that is that crisis lines are available, but also that you as the provider are a major resource, and that just asking, just checking in, just putting together a plan can really make a difference in the person's life and in their safety. And students have said it's an important topic relevant to their work. They usually enjoy the practice once they get going, and they're very grateful, as I said, to have a tool and something concrete that they can work with the patient and then send the patient away with. Some people will choose to make a Xerox copy so that the provider and the patient have a copy as well, and I think that's a good strategy. So future directions as I wrap up here, standardizing the content across classes within our program is something that we're looking at doing so that we can really educate all of our advanced practice students in certain content that they need rather than having different classes provide this in different ways. got to have more opportunities for practice. We do need to gather information about students about using the skills in their actual practice. And then we also, as I mentioned before, want to increase our focus on intervention with and management of suicidal individuals. So, thank you very much.
Well, we're going to take a few minutes for questions for you specifically, Elaine. So if anyone has a question, we can type it into the chat box. One being typed right now, so I'll read it in a minute as soon as I see it. I'll ask a question in the meantime. I wondered if you got feedback from students after they've been in the practice setting, if you've gone to hear back from them on, you know, any challenges or things that help them in terms of using these skills.
What several of them have said, and some check back and some don't, but what several of them have said is that it was really helpful to practice these skills before they had an actual person who is an actual patient sitting in front of them. So getting the words out was helpful. And that it is harder than it looks, but also that it's been very effective in terms of dialogue with individuals about their safety.
Thanks. And Adam Lesser had a comment saying that your program sounds great, and he wishes that it was a national standard for all nursing programs.
Great. Thank you, Adam.
Okay. Well, I see another question coming in. And I think there's also, Peggy mentioned that there is a webinar that SPRC and SPAN USA put on a couple weeks ago on the Washington state legislation and how they went about it. And so we've put that link on the slides and in the chat box earlier. So that has some insight onto how we might institute mandatory training for certain health professions.
Yes, definitely. And Peggy alluded to it. It was disappointing that in our state at this point, nurses and physicians were able to not be included in this, partially due to some lobbying and that was going on. But we're going to continue to work with that. And I think when we speak to our students, it's a very easy thing. They understand it's an important part of education. It's when we get into people who've been in practice for a long time, because there are continuing education requirements in so many areas, we want to be hoping that people will move this into an important category, just as I think an old analogy when I was in nursing school was, we all have our CPR training, we all have our HIV education, and of course we need to also have education about preventing suicide as well.
And a comment from Brian just emphasizing the importance of these kinds of standards for other types of healthcare providers, not just nursing programs. And then there's a question from Linda about the Cognito training that the state of Arizona, they partnered with emergency departments to create with Cognito an online avatar-based, gaming-based training for emergency department staff. And she mentions that it can also be used for primary care centers. So that's something that the state of Arizona is doing, and there's actually also a webinar on that topic, which we can send information out about for folks.
That's a great program. Our research team has been doing some evaluation of a project that's using the Cognito training with school staff as well, and it's been very well received.
And I might add that I've been working with, this is Peggy, I've been working with Cognito that is currently developing a training for primary care that will include PTSD, depression, suicide, and other behavioral risk factors. So that's something along the lines that Linda mentioned of the training for emergency departments that is right now being developed by Cognito.
Great, and there was another question from Kay Schreiber on, do you ever use training from the QPR Institute?
That's actually one of the best practices, and that's certainly an option. I'm not a QPR trainer, and there's a fee associated with some of that training. So in terms of using that with students, that's not necessarily something that we've done yet, although talking with the developer, Paul Quinnett, is also on my list to figure out how we might incorporate that without violating any proprietary information. Assist training is also another good avenue for training students as well.
Great. Well, these questions are fantastic. Thanks, everybody. I'm going to keep going, and then we will have questions and comments for all of our panel at the end of our session. So I'll just let the other two wait until we get to that point. One thing we just wanted to cover before we went to that stage of the webinar is just to take a few minutes to review some resources that you might find useful and to discuss the responses that some of you provided in a survey that we conducted last spring. In May, we asked state suicide prevention planners, many of you in the audience, about your information needs on this topic, and we also asked about the efforts you've pursued in primary care. And so this slide just shows some of the responses that you provided. And if you look at the quotes, you'll see a variety of approaches that are being used by your peers to reach the primary care sector. So the SPRC website has contact information for state contacts, and it's talking to each other is a great way to learn. The resources I'm about to review will supplement what you've just heard from our speakers. This is a screenshot of the primary care pages of the SPRC website, and the overall website underwent a major renovation this winter. So we're really excited to have the addition of the provider pages, which offers information on, in many cases, free information on toolkits, trainings, billing guides, fact sheets, and publications. So please check it out. And I just wanted to note that these pages are relatively new and we want them to evolve. So if you have feedback or suggestions for resources to include, feel free to get in touch and send us your ideas. Now just for a minute, going back to the survey that we conducted this spring, people asked for tools that suicide prevention practitioners can use to engage primary care providers and tools that providers themselves can use to respond appropriately to suicide risk in their patient populations. And we don't really have a large body of research evidence on the effectiveness of suicide prevention interventions in the primary care setting, but we know that primary care is a priority setting for intervening with at-risk populations. So to advance our collective progress in this area, we need to rely on tools like those shown on this slide and information sharing vehicles like communities of practice and lessons like those you've just heard from Maine and Washington. So this slide shows two tools that I want to call your attention to. The first is the Best Practices Registry, or the BPR, which disseminates interventions that meet criteria for effectiveness, expert consensus, or adherence to standards. And in Section 3 of the BPR, you can find a number of interventions suitable for the primary care setting that have been reviewed for programmatic and other quality standards. And one of those worth special mention is the free online training, Counseling on Access to Lethal Means, or COM. And we know enough about the role lethal means plays in suicide and the role means restriction or means counseling can play in the prevention of suicide that we want to stop and really consider how means counseling can find its way into the primary care practice. And I think Elaine touched on that a bit during the safety planning discussion. So this training is designed for providers who counsel people at risk of suicide, primarily mental health and medical providers, and it's free and self-paced and can be accessed on the SPRC Training Institute page of our website. So just quickly back to the subject of research evidence. While we're still in the early phases of building a body of research on the effectiveness of suicide prevention interventions specifically for primary care settings, I think we can look to the more abundant information on the effectiveness of primary care and behavioral health integration in general and apply lessons from those efforts to our suicide prevention goals. And a lot of the examples that our audience provided through the chat, I think, kind of illustrates that. So I know that many of you are already involved there. So here we have the Center for Integrated Health Solutions, which is a joint program of SAMHSA and HRSA run by the National Council for Community Behavioral Health Care. And while the content focuses more broadly on behavioral health versus suicide specific, I think the tools and resources have something to offer for efforts addressing suicide risk in primary care settings. And the center has really fantastic webinars on some topics that primary care providers might need to build suicide prevention practices into their protocols. And there are things like motivational interviewing techniques, coding and billing, and creating linkages between primary care and behavioral health, and even just certain office structural protocols that busy primary care offices need to think about. So these can all be found on their website, which I recommend visiting. So just as we see greater emphasis on health homes with health reform and the integration of behavioral health and primary care, we want to be thinking about how to ensure that suicide prevention is part of that integrated package. So for those of you who will have any follow-up questions after this event, this page just shows how to get in touch with us, and it lists contact information for the prevention support team at SPRC and the provider initiatives team. And all of this, of course, is also on our website, which is www.sprc.org. So we have about 12 minutes for questions for our entire panel. And I see that there are already some coming through the chat box. So I'll start to ask those. But for anyone who wants to add to that list, just put the name of the person you'd like me to direct the question to, or if it's general, that's fine too. Let's see. There are some comments about QPR trainings, and so I can, let's see, and someone at Boston University is using it for medical students. And there's also a comment about counseling on access to lethal means and how you can use it to talk with parents of at-risk youth, also for school counselors. So I think there's some more questions coming in right now, I can see.
If I can jump in with the lethal means, I think we've also, in our research project, done a lot of work with parents and kids and school counselors about reducing access. And certainly throughout the state of Washington, as well as throughout the country, people have different thoughts about firearms and rights and questions and safety. And what's been very helpful in those situations is to be able to talk about getting on the same page about us wanting to be sure that the child is safe, or that the young person or that the family member is safe, and how we might come to that we're not the police, we're not here to report, we're not judging, and certainly I, as a middle-aged, middle-class white woman, can't understand in certain situations why someone would say they need a gun in their home, and to not be telling people just don't do this, but to talk about how we might get together and be able to figure out a solution that works for everyone.
This is Peggy. Another lethal means discussion that's so important is about medications in the home. And now that more people seem to be getting prescriptions for opiates that are prescription drugs, and we know that the deaths from accidental overdose have been going up, the way in which those may be available in the home and left over from other situations, which then gives access to anyone who comes in that home, is certainly an important discussion for anyone who might be at risk for suicide or someone in their household.
Thanks, Peggy. Yeah, I think some communities have prescription take-back efforts that I've seen, and different ways of addressing that. Sandra Black said she's interested in the levels of the training issue and is thinking of doing some outreach in rural areas that might not have trained mental health professionals for doctors and nurses to refer to. Are there any thoughts on how to engage more primary care professionals in the second level of training beyond gatekeeper, and particularly in rural areas?
I'll jump in there. This is Carrie speaking. Our experience when we put out our menu of trainings that we offer for free around the state, they include gatekeeper training, which is like QPR, assist training, but we also provide a step up, that's suicide assessment for clinicians. And our experience in connecting with the primary care physicians was that they were very interested in that training. So many signed up for that training in particular rather than the fundamentals of suicide prevention. So I think that the interest is really there at engaging primary care staff in particular.
And This is Peggy. In both Alaska and Hawaii, there have been efforts to reach out and train EMTs and medics who work in rural areas who may be called in for injuries to be aware of asking about intent and risk of suicide and how to engage with the patient and the family members for preventing. And those have been very well received in both Alaska and Hawaii, particularly where these people are a big part of the safety network in the rural areas.
One question I had relates to a barrier that I'll hear sometimes about primary care providers' hesitancy to get involved, even if they think it's important, because they don't feel that the outpatient mental health capacity in their community can receive the number of patients that they might need to refer, and or they just haven't kind of reached out and created cross-provider referrals with those outpatient mental health providers if they do exist. And I just wondered if any of you can share a specific experience where someone's been able to kind of overcome that type of problem.
This is Carrie again. So for our program, what we found, and it was fascinating to me, I think, that as a part of the culture, it seemed like primary care centers do want to provide a spectrum of services within their doors, so internally. A lot of our health centers did have co-locations, so they did have behavioral health clinicians right in the health center, but really referral rates were beyond their capacity. And they did not know, they didn't have collaborations or partnerships yet with mental health providers in their community. So that was a key area that we felt primary care physicians really wanted from us, asked from our program, is those introductions and information on behavioral health and mental health resources right there in their community.
This is Peggy. Another thing that we found useful is that primary care providers can also call the crisis line, both local or the national line, for help in dealing with a patient. And while many know that this is a resource for patients, I think some don't realize this is also a resource for professionals.
Yeah, this is Elaine. That's definitely something that we talk with our students about as well. And even in big cities where there's what we would consider a good level of mental health care, often the wait lists for people who are willing to go and have insurance still can be weeks or months at a time. So using the crisis line and developing a good relationship and as Peggy said, making sure that clinicians understand that they too, and family members, that they can call and get some advice, that it doesn't have to be a crisis situation when they call, that they can also get some information.
In Massachusetts, there's a state-funded program for pediatric offices called MCPAP, which is the Mass Child Psychiatry Access Project, and that groups behavioral health professionals regionally and gives the pediatric offices free and very good access to these professionals to provide consultation over the phone. So if a primary care provider has a patient right there and needs some help with a behavioral health issue or a suicide risk, then they can call those. And there's a national network of similar programs that recently got established called the National Network for Child Psychiatry Access Projects. So that's another type of resource that's kind of building around the theme of integrated care, specifically for the pediatric population.
And I think with this, oh, go ahead.
Nope, keep going.
Okay, this is Elaine. I was just going to say with the pediatric population, we also have pretty good evidence that even when appointments are made, that they often aren't kept, or that young people and adolescents in particular might go once but don't continue to go. So the other mantra message that I think we want to keep delivering to people is we want to shore up resources in the young person's life, whether it's school or home or other trusted adults, that those, frankly, will probably be the people who have the most influence on the person and keeping them safe.
Carrie, one question I had for you. I know we have a lot of folks who are Garrett Lee Smith grantee directors or managers, and also folks in state agencies and tribal communities as well. And I wondered just if you could explain a little bit of just the logistics of your staffing. Like you described a very comprehensive program that Maine has gone through, and I wondered what types of positions did you use to provide consultation to the primary care offices and kind of liaison with the Maine Primary Care Association, and how did you structure that?
Yeah, that's a good question. I think there's 4 of us. So there's Cheryl DeCara, who's the program coordinator. She's basically the grant funder, and she's the head of the program and leads us all. There's myself. I'm the training coordinator, and so I'm a full-time person, and I do training and more, definitely. And then there are partners in our training program. They include the Maine Primary Care Association. So Becca Morin is whose staff is not a full-time position. She's a partner, though, and Maine Primary Care Association is a partner, and they really do a wealth of things in connection with primary care physicians. But again, that's just a part of the whole training program. So really, she does the heavy lift. And then there's another partner in the training program. It's the co-occurring collaborative Serving Maine, and they do some of the logistical things to help support the training program. And then that's it. So really, with very little, I think that, Peggy talked so well about people that have a passion and come to the table and really have a focus of what they think should be happening. That's what it is here in Maine. I mean, we have lots of partners, lots of volunteers, but very few staff focused on this program.
Great. Well, that's such a nice way to wrap up. I want to thank you again, Carrie, Peggy, and Elaine, and thank you all of our participants. We had a great turnout, and we really appreciate your time today, and we look forward